neurological testing. One of the best bedside tests that I've seen is not the mini-mental status examination, actually, which is widely available. But I will recommend this one because I've used it a lot in practice. The MoCA test, which stands for Montreal Cognitive Assessment, and it's available at www.mocatest.org. It's available in 5 bazillion languages, and so it can be applied to Hispanic patients as well as English speakers, and so it's very useful. I call the MoCA test kind of like the MMSE of Parkinson's because it gets better delineation of executive and frontal lobe dysfunction and other aspects of Parkinson's that can be a part of the disease compared to the MMSE. There's also other tests that can be administered by a neuropsychologist, including the AD-COG, Mass Dementia Rating Scale, clock drawing test. You can do that in the office as well. These are some clocks that folks have done that have significant cognitive impairment that you can see there, but trail making as well can be helpful. Well, what causes the dementia and Parkinson's disease? It appears from several studies of patients found in the community that dementia with Lewy bodies is probably the biggest determinant of developing cognitive impairment and dementia over time in Parkinson's patients. So dementia with Lewy bodies, you've probably heard of, is one of the top few causes of dementia in dementing patients, behind Alzheimer's and up there with multi-infarct as well, or mixed pathologies. But dementia with Lewy bodies occurs in the setting of having Parkinsonism as well as dementia within the first year of each other. So very quickly a patient dements. Classic Parkinson's disease dementia, or PD dementia, develops over time in patients. So it's a gradual process. They've had Parkinson's 5 years, 7 years, and as they get older, they may dement at 12, 13 years or have significant impairment by then. That's the classic case that I see in practice. Sometimes patients have overlap. In 15 patients that we studied at autopsy at the University of Virginia where I did my residency, actually 2 of 15 patients had met criteria for both Parkinson's and Alzheimer's disease, Parkinson's disease dementia as well as Alzheimer's disease. But having Lewy bodies up in the cortex, as I showed in that diagram from Brock, as it goes up into the brain, that's pretty classic as what thought to be the major cause of dementia in Parkinson's, not plaques and tangles as you see here. There's a plaque, and these are tangles that occur in Alzheimer's. There's the Lewy body right there. So how do you treat dementia and Parkinson's? Acetylcholinesterase inhibitors. There's actually one that's actually approved for Parkinson's disease dementia and dementia with Lewy bodies. It's helpful for both conditions. But rivastigmine is out there, and it increases acetylcholine and by inhibiting this enzyme, acetylcholinesterase. Donepezil and galantamine are also out there. These haven't been studied head-to-head, but my suspicion is that they're probably all equally efficacious, kind of similar to Alzheimer's. But rivastigmine had additional benefits in the study for PDD beyond just improving cognition. It actually also improved hallucinations in patients. So another reason to use a acetylcholinesterase inhibitor in a patient with dementia and hallucinations is that it can improve the hallucinations. There's also some recent data from Dag Arsland and others showing that memantine can improve cognition in Parkinson's disease patients. A small study of about 80 patients or so that I saw recently presented at the Movement Source Citing meeting in Paris. But these drugs are recommended for more advanced Alzheimer's patients currently and not approved for PD dementia. This is a study I mentioned for rivastigmine. It was actually published in the New England Journal of Medicine, and Murat Emre, a Turkish movement source specialist, was the lead author. And they used the ADAS-COG, which is the Alzheimer's scale, probably not the best scale to use for Parkinson's, but it was the best they had at the time to evaluate cognition. And placebo-treated patients had a little bump up like placebo can commonly do with improvement, followed by a decline over time. Whereas patients treated with rivastigmine, a huge number, 329, a very large study, had a significant improvement at 16 weeks, and it was sustained out to 24 weeks. So there were significant improvements on this scale with rivastigmine over placebo. Well, how about practically? In addition to medications, you got to educate the patient and the family about things. This is a progressive disease. It's going to get worse. plan way in advance about, well, what are you going to do if you what are you going to do if you can't handle him at home anymore as he gets demented? I commonly see exasperated spouses of PD patients that are just worn out because they don't have enough help around, and they're trying to do everything themselves, and they have their own medical issues, and they have depression. So you got to look at the whole family and how they're going to handle this disease going forward. Can children be around or help spell mom at night? Those kind of things. Planning with social work for assisted living or nursing home placement as the disease progresses. So think about that. That's important. And don't change environments if you can for demented patients. Keep it kind of stable and set until you have to get them to the nursing home and just can't handle it at home anymore. Well, what's the clinical importance of dementia and Parkinson's? Poor tolerance of PD meds. A key drug that you should not use in patients that have significant dementia and PD are dopamine agonists. They can worsen hallucinations, as I mentioned, and you should get folks off dopamine agonists if they have dementia. Drug-induced hallucinations, again, with the dopamine agonists more often. And there's certain other drugs that you should avoid that are commonly used in Parkinson's. Anticholinergics, so benztropine and trihexyphenidyl. Pull those off because they affect acetylcholine. They're anticholinergic. And what do you do to treat dementia? You increase acetylcholine. So certainly get them off those to try to improve things. MAOB inhibitors you may want to pull off. Amantadine is one of the early drugs you may want to pull off. But almost all patients remain on levodopa as the basic med to treat their Parkinson's, but others may have to come off. It's a big risk for nursing home placement. Probably the biggest risk is dementia for getting in a nursing home, according to Chris Getz's research. And if you have dementia, as characterized by neuropsychological testing, you're eliminated as a candidate for deep brain stimulation surgery. So we don't do DBS in demented patients. And it increases your mortality. Compared to patients without dementia, there's a significant increase once you develop it for increased mortality. Okay, so that's enough about dementia. How about olfactory dysfunction in Parkinson's disease? Sometimes having olfactory dysfunction is good, as these ladies would like to have probably in an underarm sniffing test there. But it's unfortunately commonly not noticed by Parkinson's patients. I'd say in my practice, I've asked patients right in front of me in the office, half the time they have no clue they've lost their sense of smell. But the spouse will, more PD patients are men, maybe 60-40 or 65-35 in most clinics, and the wife will sit there and look at me and, yeah, you can't smell anything. They're aware of it, but the patient's not very aware. But there's loss of, there's Lewy bodies in the olfactory system, neurons, and there actually are conflicting reports of the pathology of why this is occurring, but some studies have shown that there's more of these nerve cells that are present in the olfactory epithelium compared to less. So we don't know the exact pathology, but it certainly is present very early in PD. It may be, given it's present very early and before the motor symptoms, it may be a useful and preclinical detection in Parkinson's disease and early diagnosis. It's unrelated to disease duration or stage. So when someone presents with Parkinson's, their deficit is pretty darn bad. It's bad later in disease too. It doesn't change a whole lot. And giving levodopa or other drugs does not make a big difference in the olfaction. Interestingly, and this is the basis of a recent study called PARS, in first-degree relatives, that is brother, sister, mother, father, son, daughter, okay, in first-degree relatives of PD patients, they actually look for olfactory deficits. In those that had olfactory deficits, they had this scan for Parkinsonism that was done of the brain. They found that 10% of them actually developed Parkinsonism and probably PD after 2 years. So if you're a first-degree relative of a PD patient and you have impaired sense of smell, it may be a good idea to, if we develop disease-slowing therapy, maybe this population would be a good group to try out disease-slowing drugs.